Imagine this. You've just come through cancer treatment, surgery, maybe chemo,
Yeah.
and you get that moment finally to breathe.
Yeah.
But then that little question starts, doesn't it?
Mhm.
Is it really gone? Are there, tiny cells left just waiting? It's that mix of hope and anxiety.
Absolutely. It's a huge challenge. How do you really know?
Exactly. And today, we're doing a deep dive into some, well, pretty groundbreaking research that might offer a new way to answer that. We're looking at non-small cell lung cancer.
A very common type.
Right. And this cutting-edge approach called molecular residual disease detection, MRD.
Mm-hmm. Our mission really is to unpack what researchers found in an exploratory look back at the big ADOR clinical trial.
Okay.
Specifically, how MRD, using something called circulating tumor DNA, ctDNA, can predict if the cancer might come back. And this could genuinely change things, like personalized care for patients with a specific kind of lung cancer.
Which type is that again?
It's the EGFR mutated kind, non-small cell, that's been removed surgically at earlier stages, especially when they're treated with a drug called Osimertinib.
And we should probably mention the source here is Nature Medicine.
Yeah, that's a top-tier journal, very rigorous.
Tells you this isn't just preliminary stuff. It's been seriously vetted, which, matters a lot when you're talking about cancer care.
Definitely.
So, okay, to really get why this is a big deal, let's set the scene a bit. What's the current picture for this type of lung cancer, and what's the puzzle here? Let's start with osimertinib.
Right. So osimertinib, it's what's called a third-generation EGFR-TKI, a tyrosine kinase inhibitor.
Fancy name.
Yeah, but it's already really important. It's standard practice, recommended as adjuvant therapy. That's treatment after surgery for these specific patients we mentioned. Early stage, EGFR mutated, surgically removed lung cancer.
And the original trial at EGRA, that already showed good results, right?
Oh, absolutely. Significant improvements. Better disease-free survival, DFS, and overall survival, OS. Like the 5-year overall survival was 88% for the osimertinib group versus 78% for placebo.
Wow.
Yeah, and the hazard ratio for death was 0.49. So basically, almost halving the risk of death. That's huge in oncology, a major step forward already.
Definitely sounds like it. But like you often find in science, one answer leads to more questions.
Exactly. Despite that success, a kind of worrying trend emerged.
Oh, was that?
They saw an increase in recurrences after patients finished the standard 3 years of osimertinib.
So treatment's done, things look good, but then...
But then later, the cancer comes back for some people.
Yeah.
So the question became, how do we know who might need longer treatment, who's really high risk even after 3 years?
And how were doctors trying to figure that out before? What's the usual approach?
Well, the standard is regular scans, like CT scans, serial imaging. But the problem is scans only see things once they're, big enough to see, macroscopic disease. Plus, things can look weird on scans after treatment anyway. Changes in normal tissue.
Right, scarring and stuff.
Exactly. And nobody's totally sure how often you should even do the scans. It feels a bit reactive, like waiting for a problem instead of spotting it early.
Like waiting for the flood instead of finding the tiny leak.
That's a great analogy. We needed something much more sensitive, something proactive.
And that's where MRD and this ctDNA come in, the whole liquid biopsy idea.
Precisely. It's a game changer, potentially. ctDNA is basically tiny bits of DNA shed from the tumor into the bloodstream.
Okay.
And you can detect it with a liquid biopsy, usually just the standard blood draw. It's minimally invasive, and it lets you check for tumor burden genetic changes.
And MRD is specifically looking for this after the main treatment.
Exactly. After surgery, after chemo, when you think everything's gone. Detecting ctDNA, then, is what we call MRD. And it could be a super early warning sign of recurrence.
So how does the test actually work? Is it just looking for any cancer DNA?
No, it's much smarter than that and really personalized. The technology, sometimes called tumor-informed testing or radar panels.
Radar.
Yeah, like radar. It first analyzes the patient's actual tumor tissue, the one that was removed surgically.
Okay, from the original surgery.
Right. To find its unique pattern of mutations, its genetic fingerprint, basically. Then it designs a test specifically to look for those exact mutations in the patient's blood over time.
So it's customized for each person's cancer.
Highly customized. It's like tuning a radar to only pick up signals from that specific plane, ignoring all the background noise. Makes it incredibly precise.
And there was already some evidence this could work, even before this big analysis.
Yes, definitely. Earlier studies in early-stage non-small cell lung cancer had already shown that finding MRD in the blood could predict recurrence months before it showed up on a scan.
How much earlier?
The lead times varied, but some studies showed median leads of like 3.4 months, even up to 7 months in others.
Wow, that's significant.
It really is. So that kind of set the stage, showing the potential leading into this deeper look within the Adjuvant trial.
Okay, so let's get into this specific analysis. What exactly did they do?
So this was what's called a retrospective post hoc exploratory analysis, meaning they looked back at data and samples already collected during the main Adjuvant trial.
Okay, not a new trial, but a deeper dive into existing info.
Correct. They focused on a subset, 220 patients from the main trial. About half got osimertinib, half got placebo, 112 versus 108.
And these 220 patients, what was their journey?
They all had their tumors completely removed surgically. Some might have had adjuvant chemo first if needed. Then they were randomized, got either osimertinib or the placebo for up to 3 years.
And they collected blood samples the whole time.
Yeah, longitudinally. Starting from day 1 of the randomization, they collected plasma samples to test for ctDNA later.
Got it. Were these 220 patients pretty representative of the whole Adjuvant group?
Broadly similar, yes. The overall Adjuvant trial had 682 patients. This subset had maybe slightly fewer patients with the earliest stage IB.
Okay.
About 21% here versus 32% overall. And also fewer Asian patients, 45% versus 64%. Mostly just down to which samples were available and some local rules about sample collection. Just important context, you know.
That'll good to know. Okay, the big moment.
Yeah.
What did they find? How well did MRD predict things?
Right, let's start right at the beginning. Baseline, before treatment started. Only a small fraction, just 8%, that was 18 patients out of the 220 actually had MRD detected before they even got randomized.
Only 8%. But what happened to them?
Well, this is striking. Even though it was a small group, their outcomes were generally poor. 17 out of those 18 patients eventually had a DFS event, disease-free survival event, meaning recurrence or death.
So having MRD right at the start, even before the adjuvant therapy, was a really bad sign.
It seemed to be a very strong indicator of high risk, yes.
But then they started the treatment, osimertinib or placebo. Did the drug make a difference for those few who started out MRD positive?
Now that's where it gets really interesting. In the placebo group, none of the 13 patients who were MRD positive at baseline cleared it. Their MRD stayed detectable.
Okay.
But in the osimertinib group, there were 5 patients MRD positive at baseline, and 4 out of those 5 actually cleared their MRD during treatment. It became undetectable.
Wow, so the drug actively wiped out that residual disease in most cases.
It certainly looks that way. Those patients who cleared MRD generally had longer DFS compared to those in the placebo group who remained MRD positive. It suggests osimertinib isn't just like holding things back, but potentially eradicating those last few cells.
That's a powerful finding. What about looking across the whole study period, not just a baseline? How many people stayed MRD free?
Again, a really stark difference. Overall, throughout the study, 87% of patients taking osimertinib remained MRD negative, completely free of detectable ctDNA.
87%, that's high.
Very high. Compare that to the placebo group, where only 51% stayed MRD negative.
So just over half on placebo versus almost 9 out of 10 on osimertinib.
Exactly. It really paints a picture of the drug's effectiveness at this deep molecular level, preventing recurrence.
Okay, this brings us back to that lead time. You mentioned earlier studies showed MRD predicting recurrence months ahead of scans. What did this analysis find? How much warning did MRD give?
This is maybe one of the most crucial findings. Across both the osimertinib and placebo groups, when MRD was detected, it happened a median of 4.7 months before a recurrence was picked up on an imaging scan.
4.7 months.
Yeah.
Almost 5 months lead time.
Yes. Nearly half a year's warning, on average. Think about what that means.
That's huge. That's potentially enough time to actually do something, right? Instead of waiting for the scan.
That's the hope, exactly. It opens up possibilities for proactive intervention that just weren't there before.
So how did things look when they combined the endpoints? Like, looked at either recurrence on a scan or MRD detection, whichever happened first?
Using that combined endpoint really drove home the benefit of osimertinib. Only 25% of patients on osimertinib had either a DFS event or an MRD event.
Only a quarter.
Compared to 69%, more than 2/3 in the placebo group, the hazard ratio there was 0.23.
Which means?
A really big reduction in the risk of having either event if you were on osimertinib. A very strong protective effect shown by the drug.
Okay, this leads to that tricky part we talked about earlier. What happened after the planned 3 years of treatment finished? Did recurrences spike then?
Yes. This is a really key insight for thinking about future strategies. In the osimertinib group, the majority of events, 68% of the DFS or MRD events, actually happened after they stopped treatment, either completing the 3 years or stopping early for other reasons.
So the protection is strong while they're on it, but the risk goes up afterwards.
It seems so. And even more specifically, of those post-treatment events, 58%, more than half, occurred within the first 12 months after stopping osimertinib.
Within a year of stopping.
Within a year. Now, overall, the rate of being free from DFS or MRD events was still pretty good, 66%, even 2 years after stopping osimertinib, so there's definitely long-term benefit. But it does suggest that for a significant group, the risk comes back relatively quickly after cessation. It highlights this potential window right after stopping, where maybe monitoring needs to be intense, or maybe some patients need longer treatment.
Fascinating. Did they look beyond just detecting MRD?
Yeah.
What about other genetic factors, like other mutations in the tumor?
They did. They looked at co-occurring mutations present at baseline. And the most common one found alongside the main EGFR mutation was in a gene called TP53.
TP53, I've heard of that one. It's often linked to cancer, right?
Yes, it's a very well-known tumor suppressor gene. Mutations there are common across many cancers. In this analysis, 45% of the patients had a TP53 co-mutation.
Almost half. So what did that mean for those patients? Was it worse?
It did seem to correlate with tougher disease, yes. Patients with TP53 mutations were more likely to have had more advanced disease stage to begin with, more likely to have received adjuvant chemo. And they also had a higher risk of having a DFS or MRD event, whether they were on osimertinib or placebo. So it suggests TP53 mutation might mark a more aggressive biology.
That sounds discouraging for those patients. Did osimertinib still help them?
But here's the really important and actually quite reassuring finding.
All right.
The benefit they got from adjuvant osimertinib was similar, regardless of whether they had a TP53 mutation or not.
Really? So the drug worked just as well, even in that higher risk group?
That's what the data suggests. Osimertinib helped reduce the risk significantly for patients both with and without TP53 mutations. It means the drug provides broad benefit, even when these other challenging mutations are present. That's actually great news.
That is good news. It means the treatment isn't just for the easier cases.
Exactly. It helps tackle the tougher ones, too.
And one more technical point.
Yeah?
Did they compare using these fancy personalized radar panels versus just looking for the known EGFR mutation in the blood?
Yes, they did that comparison, and it was quite telling. Simply detecting the original EGFR mutation in the blood could predict recurrence, yes.
But
the full tumor-informed radar MRD panels, the ones looking for that whole personalized fingerprint of mutations, they performed better.
how so?
They showed better sensitivity, meaning they were better at actually detecting MRD when it was there. 65% sensitivity for radar versus 54% for just EGFR mutation tracking.
Okay, a bit better detection.
And crucially, a much longer lead time. Remember that 4.7-month median lead time for the radar MRD detection?
Yeah, almost 5 months.
If you just looked for the EGFR mutation alone, the median lead time was only 1.0 month.
Oh, wow. So only a month's warning versus almost 5.
Big difference. It really underscores the value of that personalized, comprehensive, multivariant approach for MRD testing in this context. You get a much earlier warning signal.
Okay, so pulling all this together, what are the big takeaways, the implications? This MRD detection sounds like a really powerful new tool in the box.
It absolutely seems to be a sensitive way to spot recurrence risk, potentially way before scans can. And if this gets validated and integrated into practice, well, the potential for personalized care is just massive.
You could maybe identify those high-risk patients, the ones whose MRD pops up early or maybe never clears.
Exactly. And maybe they're the ones who need longer treatment with osimertinib, or maybe even adding another drug, some kind of combination strategy.
Right, when they need it most. But also, what about the other side?
The other side is just as important. You might identify patients who stay consistently MRD negative for years. Maybe they are the ones who could safely stop treatment earlier or avoid extended therapy altogether.
Sparing them the side effects, the cost, the anxiety, improving their quality of life.
Precisely. That's the dream of personalized medicine right there. Tailoring the intensity and duration based on individual risk.
It's still early days in some ways, right?
Yeah.
This is an exploratory analysis.
Very important point, yes. While incredibly promising, we need more research. Specifically, prospective studies designed from the start to test these ideas.
What questions do those studies need to answer?
Key questions are, what's the optimal duration of adjuvant treatment? Is 3 years right for everyone? Should some get more? How often should we actually do the MRD testing after treatment? Every 3 months, 6 months, a year?
Yeah, practical questions.
And maybe the biggest one. If MRD is detected, what exactly should doctors do? Should they immediately restart treatment, change therapy, just monitor more closely? We need evidence-based guidelines for how to act on an MRD result.
So how do we get those answers? Are studies underway?
Yes, thankfully. There are ongoing trials looking at some of this. You mentioned Target earlier.
Right, the one looking at 5 years of osimertinib.
Exactly. That's aiming to address the duration question, at least in part. And other studies are being designed to look specifically at MRD-guided treatment strategies. It's a very active field right now.
Good to hear. And finally, you mentioned limitations earlier. The sensitivity wasn't 100%, only a subset of patients.
Right. Important to acknowledge. The assay sensitivity was 65% in this study. That means it didn't pick up every single case of recurrence beforehand. And yes, it was a subset.
But the tech is improving.
Constantly. Assay technology gets better all the time, more sensitive, more specific. We can probably expect future versions to be even better at detection. It's also worth noting they had very few technical failures with the assay they used here. It worked reliably.
So even with limitations, it feels like a significant step forward.
Oh, definitely. It's a clear signal of where the field is heading. It really does feel like we're on the cusp of using these molecular tools to manage cancer much more effectively. Less guesswork, more precision.
Which brings us nicely to the end of this deep dive. We set out to show you how tracking this circulating tumor DNA, this MRD, could be a really powerful predictor for cancer coming back in this specific type of lung cancer.
And how it could really inform those crucial decisions about treatment, moving us away from that one-size-fits-all model.
So for you listening, the key takeaway is how science is getting incredibly sophisticated at tailoring treatment right down to the individual's molecular risk.
And maybe a final thought to leave you with. If we can get this good at detecting tiny amounts of disease after treatment, could we eventually use similar technology even earlier? Could it shift the whole paradigm?
How do you mean?
Well, instead of treating recurrence when it happens, could we move towards truly proactive, personalized prevention strategies, using MRD perhaps to guide interventions that eradicate the disease before it ever gets a chance to establish itself again? What doors might that open for the future of cancer care and really for preventative health?